Now, Dr. Peter Ahlering.
Thank you. I don't know if anybody can hear me okay. I like to move around a little bit, so. Well, it's tough to follow that amazing talk from Jen Myers, and obviously it was a story that had a lot of sidelines to it, which includes, of course, hope, perseverance, fortitude, discussions bringing in science and technology, and obviously then the idea that things often happen on their own. So it's an interesting story amongst also the heart-wrenching way she delivered. So we appreciate again her doing so, and it's a tough act to follow. So with that said, I'm going to try to talk about more mundane subjects perhaps, and I do recognize a lot of faces in the crowd, and I'm sure a lot of you have heard some of these things before, but hopefully won't be too repetitive. Please know that you can always, if you have questions, you can always contact me in the hallway if you want to talk about things, and I'm happy to answer what I can. If there's something more specific, we don't have time to discuss things here at the end. So with that said, we'll try to get underway here. And I think I'm going to press the right button, hopefully. So I'm here to discuss this morning just general concepts of fertility first. And it's always a lot of things to discuss and communicate. And hopefully give you a good overview of what some of the concepts and misconceptions are out there. And Jen touched on some of these things, and there's a lot of myths in the realm of reproductive medicine, because there's a lot of things that people just don't know and understand. But hopefully we'll be able to at least discuss some of the things that can be useful going forward for you. As she mentioned also, I mean, you're definitely not alone. There's about 11% of the population suffers with infertility, and also what we call self-fertility, which is just basically people having a delayed time to conception or difficulty conceiving, though not necessarily impossible. So the terminology often gets a little confusing as well. But a lot of fertility issues are related to male and female factors, of course, and it's not simply female factors alone. Obviously, egg and a sperm make an embryo and a successful pregnancy, so obviously the sperm are a big deal. So we can't point to the egg alone. But a lot of patients do have primary infertility, and a lot are secondary infertility, which basically means they've had a conception or even a successful pregnancy in the past, and they're having difficulty with the second go-around, so to speak. We all know that infertility in women increases with age. That has to do with, as we'll get into, quantitative and qualitative factors. But you can see on the graph here that the likelihood of becoming pregnant declines, and pretty much around the age of 50 is 0 with natural conception. And obviously, as such, the rate of infertility rises. I mean, I don't think any of that's particularly shocking, but I think that as we go along, we'll get a better idea of why this is. So again, I referenced that men are equally affected by fertility issues, and indeed age affects men too. I don't think that's a concept that's new to people, but as we get older, quantitative and qualitative factors of sperm decline. And this is obviously can be a significant issue. It's not just about quantity. Everybody talks about count with the sperm, but it is a lot to do with qualitative factors as well. So I think that's an important concept that, I do hear these things every day where it's like, well, perhaps my partner has conceived pregnancy in the past or initiated pregnancy in the past, as if that somehow makes everything okay. and the fact that the possibility that time is not involved, but indeed it does. It affects guys as well. We focus a lot in this particular discussion about the biologic clock. And this concept, I think, is critical because everybody seems to know or believe and understand that as females age, the probability of pregnancy goes down, and there is this magic number of 35 out there, wherein people believe that I'm getting old all of a sudden. One day I'm 34, next day I'm 35, and suddenly I'm getting old. Well, I mean, obviously it's not that dramatic, but indeed we do recognize the idea that as females age, there's going to be an effect on the probability of conception any given month, naturally. And it has to do, on the left side there, the oocyte or egg quantity is really a big thing that we focus on because that is something that we can measure readily. We can do things with blood tests and ultrasound that we'll talk about that give us a significant idea of the quantitative aspect of how many eggs are there. And the qualitative aspect is a little more elusive. It's not something that we can assess directly through blood work or any other simple X-ray, ultrasound means. And I think this is obviously a significant concern or problem because everybody, again, understands the idea that I'm getting older, the quality of my eggs are declining. And people do have the impression that all my eggs are bad. Again, it's a misconception that suddenly at age 35, everything goes downhill, so to speak, rapidly. But that's just not true. We know that there are 23 chromosomes in the egg and 23 in the sperm. They join together to make an embryo that is, of course, 46 now, XX on the female, XY for male. An aneuploidy is an abnormal number of chromosomes, too many or too few. For example, Turner syndrome, there's a missing X chromosome, and we call it monosomy X. 45XO is another term that you might see. And Down syndrome is an extra number 21 chromosome. I mean, these are very familiar to people, but these are just in general lumped into the group of chromosomal abnormalities we call aneuploidy. So quality of eggs refers to this concept that the percentage chance that any given egg makes a successful embryo, the chance of that egg making a baby goes down as we get older. That's this concept of quality. And it certainly isn't this idea that all my eggs are bad. Of course, we would never know that. How could we possibly understand if a given person's eggs are bad? You can only discuss what we have seen in the past. And that doesn't certainly mean in any given individual that all my eggs are bad going forward. And I think that it's just not true, although it's a common misconception again. Again, we know this slide just shows that there is decreasing ovarian reserve with time. So the ovarian reserve is a term we use all the time that is trying to convey the idea of quantity of the eggs and follicles. People also understand, as the far left of the graph shows, that you have all the eggs that you'll ever have when you're born. Actually, when you're inside your mother's uterus, you have the most eggs you'll ever have at about 20 weeks of gestation. The estimate or guess, based upon studies that are complicated, but nonetheless there is an estimate that it's around 7 million or so in the average person. Now, of course, that varies depending upon the individual and genetic factors that we don't understand, but you actually have the most eggs before you're even born. And when you're born, as the graph shows, the number goes from an estimated 7 million down to 2 million. So you've lost more eggs before you're even born than you'll ever have. It's kind of an interesting, strange thought, but that's actually true. And by the time that a woman has her first menstrual period, around age 11 on average, it's down to about 400,000. again, a huge percentage decrease before you even have one menstrual period. Then again, the graph shows that around age 35, it's down to about 25,000, and the declining slope of the graph just indicates that people start to see an accelerated loss of eggs at that time, follicles or eggs. And follicles are just the fluid-filled sacs on the ovary that you see in an ultrasound. And it's a reflection of how many are there at any given time. But the number declines more rapidly as you get into that mid-30s range. And this is an important thing because this is when things start to change. And I think that's really the takeaway message for this, is that it's not just how good the eggs are, but it's the quality, so to speak, the potential of any given egg relative to the quantity. Obviously, that's a very individual concept. It's not something that applies to a group. It has to be determined on an individual basis, and everybody is different. Then you'll see, of course, the average age of menopause is around 50. That essentially is when there are no eggs left. And you know, people enter that stage at different ages. You know, this graph depicts an average. Some people are younger, some people are older. Everybody hears the stories about grandma that was 60 years old and had menopause and had a baby when she was 48 and things like this. I'm sure it happens. It's just not a very common event in general, but it certainly is possible. This just shows the different stages of development. When we talk about follicles visible in the ovary, that's at the end there, the fourth blue circle, is it called an antral follicle. Those are ones that are visible on ultrasound examination. Down the bottom left, the primary follicles, or primordial follicles, are not visible. These are ones that are in the ovary, just not able to be seen. And this is the pool from which the antral follicles eventually come. But it's a developmental process. And you have millions, if not hundreds of thousands of primordial follicles that are primordial eggs in the ovaries, but this is rapidly depleted. On estimate, it takes maybe 10,000 primordial follicles to yield one antral follicle. And this is why eggs are being lost at such a high rate. Most of them are lost well before they get to that antral stage. As you see, thousands are lost from the transition of primordial to what we call primary follicle. And this is due to a process called apoptosis, which is just a fancy term that means programmed cell death, where these eggs and follicles are destined to die. And thousands do so at each stage of the game. And this is why the number of antral follicles is what we look at. It's what we can see on ultrasound, and it is the pool at that particular time that has potential to actually grow and yield a viable egg in the end that ovulates. The lower right, I think, is an important picture because it underscores some important concepts also, that the egg inside this follicle that we call a grafting follicle, that's the one that's about to ovulate, it's called a grafting follicle. And it is a very, very complicated unit with many different types of cells. The cells that immediately surround the egg here in the center, this is the egg here, and this immediate surrounding group of cells called the cumulus is obviously important for transmitting signals directly to the egg, and it has an impact on how that egg develops. The surrounding cells on the inner layer of the grafting follicle, on the inner layer of the follicle, the granulosa cells, obviously, again, they communicate in ways chemically with the other cell types. It's a concert of events that has to occur that leads to a, quote, good egg. So it's a very complicated process, but it's not just the egg itself. It has to do with these follicular cells and their function that can have an impact on egg quality also. And this is obviously before it ovulates. We use the antral follicle count as really a fundamental evaluation of how many follicles, again, are available at any given stage. Jen mentioned polycystic ovaries, which by definition, a polycystic ovary is one that has more than 12 follicles. That's at the upper end of the bell curve. And many of you may have seen me draw these graphs out before. I use the bell curve concept a lot because I think it helps, because it basically is a description of what we might see in a population of people that says at any given age, most patients will fall in the range of what we call normal. Those that fall outside that normal range are at risk for having problems. At the high end of the range is going to be this polycystic ovary idea. At the low end of the range is a term called diminished ovarian reserve. Everybody's probably heard that before. But it basically suggests that if you're at these ends of the spectrum, that there's a problem. And it may be a different sort of issue, but the ovaries just simply don't function normally at the ends of the spectrum. They become unpredictable and difficult to work with in some sense. And again, Jan's story underscores that when one time you might take medications and have no follicles, hard to imagine, and the next time you do the same medications and have an excessive response or too many with polycystic ovaries. It's this unpredictability that makes things complicated and difficult sometimes. But yet that's part of the problem. That is the dysfunction that involves the ovary itself. And the same at the lower end of the spectrum, where there's diminished ovarian reserve. It doesn't necessarily mean the eggs are good or bad. It just means there's not very many. But in saying that, it suggests that the ovary just doesn't function as it would if there were a normal average number of follicles, the average follicle count. So again, it's an important concept that I think is often lost. I mean, this is not a qualitative sort of assessment or statement. It's a quantitative statement. And we really cannot comment about quality while the eggs are actually still inside the uterus, inside the ovaries. So it's important, and people automatically think, gosh, my eggs are bad if I don't have very many. Or, as Jen's story again depicts, if I have 25, wow, I'm gonna have like 5 kids. I mean, it just doesn't, again, work that way. It's a quantitative statement. Obviously, we understand that the more you have, the more likely that one or more of them is going to actually make a successful pregnancy. But again, at the lower end of the spectrum, that doesn't mean that they're all bad. So I think that's important to keep in mind. The biologic clock, the quantitative aspect is fairly easy to assess. And this basically is blood tests and ultrasounds. And I think this is a great service and that they have at the event where people can have these blood tests drawn. My understanding is there's no cost, and to assess the fertility status as it stands today. So that's what it does. These blood tests and ultrasound are designed to try to give a snapshot at any point in time what a patient might have with respect to the follicle count, the ovarian reserve. And again, that's a huge concept to do. It takes literally minutes to do a vaginal ultrasound and get this idea. And I can't underscore how critical that is, because so many decisions that we make in the context of what we do, how we do it, what your options are, revolve around these simple things. And if I had to pick one, it would be the ultrasound. The blood tests like the AMH, the FSH, and the estradiol or estrogen levels are helpful, but they give more of an idea of how the ovary functions. It's what we call the responsiveness, not so much just the raw number of how many we have. But again, when it comes down to egg factors or ovarian factors, we're really trying to understand the quantitative aspect, because we don't have a way to evaluate quality per se. Again, just showing that the most useful blood test that we have currently is this AMH. In the olden days, we had the FSH and the estrogen levels, which we still use, but they are not very helpful or predictive relative to AMH. AMH has got its issues as well. It's a blood test that's trying to give you an assessment of what's happening at the level of the ovary. So it's more of an indirect assessment. It's helpful and useful and gives us some concept of how the ovary functions, and the follicles gives us an idea of how many there might be. However, it certainly doesn't replace the ultrasound. It can only be used adequately in conjunction with the ultrasound. So really, they're both very helpful and give us different pieces of information. And you can't really use one without the other fully. If I had to pick one again, I'd take the antral follicle count, because it is most practical in managing a clinical situation, but it is nice to have both. This is a picture I've been showing since 2007. This is just a classic example that I'm sure many of you have stories like this. This is a patient who was 39 years old and came into the office having been on Clomid for 6 or 8 months, and just couldn't understand why she wasn't having success or getting pregnant. She had irregular periods. Doctor puts her on Clomid and regulates the cycles to some degree, never really understanding or having a diagnosis of what was the problem, other than, hey, you're not ovulating. Here's take some ovulation medication, and there you go. Well, you know, this patient in about 30 seconds, I was able to just do an ultrasound and see that she's basically has diminished ovarian reserve. Of course, being 39 years old is high risk. As we've referenced previously, that age has significant influence on the quantitative aspect of ovarian function. And indeed, on the right ovary, you see that there are 2 follicles, those little dark circles in the middle of the ovary. Those are antral follicles, and there's only 2. On the left side, as I've outlined in yellow, there was none, not one follicle visible at that time. So the actual total follicle count was 3. On the picture I showed 2. The FSH was normal, and she came to me saying my FSH is normal. The reason it's normal is because the estradiol level is 300, and the estrogen level, high estrogen suppresses the FSH production in the pituitary gland. So of course, if you just look at the FSH, as we used to do back in the olden days, as I said, you would think this looks good. However, clearly abnormal, because there's not very many follicles, number 1. And number 2, the FSH is indeed abnormal if you take into consideration the estrogen. Now, of course, we use the AMH as well, which is much more accurate and predictable in discerning low reserve from blood work. But again, the ultrasound is simply indispensable. So, common factors that affect female fertility, and you see in the picture there, that's a polycystic ovary. Again, greater than 12 follicles per side or per ovary is by definition PCO. And PCOS is different. The syndrome of PCO is different than simple PCO by itself. PCO just means there's a lot of follicles, as I said, more than 12. The syndrome, as people may have heard me say, is a constellation of signs and symptoms that constitutes a disease entity. So there's other things that have to go along with the polycystic ovary to be defined as a syndrome: irregular periods, blood test abnormalities, things like this. Another common misconception is that somehow diabetes is involved, or pre-diabetes or insulin resistance is involved as part of the diagnosis, and that's just not true. It's simply blood tests, ultrasound, and history factors that go into defining the disorder of polycystic ovary syndrome or PCOS. Diabetes is a different issue, often coincidental with PCOS, but certainly not part of the diagnosis itself. Other types of ovulation problems that we're most interested in is diminished ovarian reserve, because obviously patients can have irregular menstrual cycles, and one can have PCOS and one can have diminished ovarian reserve. important to know the difference because at the end it completely defines or changes how you might approach that particular situation. Tubal damage, endometriosis, what I refer to as pelvic factors as a group are also important, but not as common as what people might think. Certainly tubal blockage is, in my experience, almost a rarity, frankly. And tubal damage, but not blockage, is another issue, but certainly along the spectrum of tubal problems. One end is normal tubes, the other end is total blockage, but in the middle ground there can be levels of damage that have an impact on the tubes. Just because they're open doesn't mean everything's good. So tubal damage is a category that I think is important, but tubal blockage, frankly, is not very common. Endometriosis, not uncommon, controversial on how significant that is as a diagnosis, but suffice to say, we do know that it influences female fertility. Uterine and cervical causes are, again, in my experience, very unusual. Uterine factors are mainly defects in the structure of the uterus, not very common. But again, easily ruled out with simple ultrasound. So blood test ultrasound, and you pretty much have a good view of ovarian, uterine, and even tubal patency with those simple tests that can be done in one day, even in an hour. You can figure all these things out. So the steps that you really need to take is to get the diagnostic evaluation. And again, I've just alluded to the idea that both male and female factors can be determined very quickly. I mean, it takes literally a day, blood test, ultrasound, and you've ruled out a significant portion of female factors with the uterine and the ovary. And you get a glimpse of ovarian function with the blood test. And the male test, which I'll talk about later, it can also be done one day, one simple semen collection, and you pretty much can learn everything that we know in the world of science currently that can help make decisions about how to address the couple's fertility issues on the male side. Obviously, both are important. You can't really manage a couple's infertility when you only know about one side of the story. So you really then just need to address these things on a personal basis, because there are basically 4 treatment options in the world of infertility. One is to do nothing. I mean, certainly that's not inappropriate. I mean, sometimes that is the right way to go, and just basically stay away from doctors, as I say, and give time. Tincture of time to some people is really all they need. Obviously, in my experience, it's not a very common thing. Most people have been down that road by the time they come to see me, but on the other hand, occasionally it does come up that sometimes you just need to give it a little bit more time. And that's not to brush things off and say, call me in a year if you're not pregnant. It's, look, give it a few months. If not, let's talk again. Ovulation induction is merely taking medications to induce ovulation. People have heard about different things, pills and shots. Pills are things like Clomid, letrozole. A third one, metformin, is used in certain circumstances. So there are a variety of different medications on the pill side that can be used basically determined by the individual characteristics of the patient. Understanding how the ovaries function, and you can select one over the other. Injectable medications basically are, hopefully there's no pharmaceutical rep friends of mine in the crowd, but I'm going to say that basically they're all the same. They are similar in how they work and chemical makeup, but injectable medications, sometimes used in combination with pills, very effective at inducing ovulation in the majority of patients. When you choose the right people, it works very well, and you have to be careful, of course, but you can usually obtain, at least induce ovulation with medications in the right couple. IUI is used often in conjunction with ovulation induction. It's kind of like peanut butter and jelly. A lot of times people think it just goes together. So much so that we call an IUI cycle one in which we're using ovulation induction with IUI. But obviously they're 2 different things. The most important part of an IUI cycle is actually getting the multiple follicle growth and development with the medications. That is on a relative basis, more important than the actual IUI itself, even in the context of male factors. So the ovulation induction aspect of an IUI cycle is critical. IUI itself is obviously important, but in the context of male factor, or if there is a cervical factor, again, certainly IUI can have a significant impact. If there is no male factor or cervical factor, which are the traditional uses for IUI, if those don't exist, then the relative factor impact of the IUI is less, is minimal. In vitro fertilization, of course, which is now significantly different in the last 20 years than it was when I first started. So there have been a tremendous number of advances and more applications for these situations with IVF, and the science is just amazing how it's burgeoned over the last decade especially. But third-party reproduction I put in there as a subset of IVF, because to do third-party reproduction in general, you need to do in vitro, egg donor, things like gestational surrogacy and all. But the strategies that surround IVF have significantly changed with the advent of these technologies like genetic assessment of embryos, the advent and improvement in techniques for egg and embryo freezing. So these types of tools we use in lots of different ways now under the context of IVF, is even in the context of egg and embryo donation. So obviously we're here to help, and we're at MCRM always trying to squeeze out go the extra mile to help patients have success. And if you have questions and things and you're interested in talking, I'm happy to do so. We have a booth out there, and if you want to basically make a consultation or at least inquire about some of the things we do, please feel free to do so. You can contact us via phone or email as well. So I appreciate your time and attention. Thank you.